Yes,
Maybe
there
4
is.
years. Yes. So Baraka is finishing his PhD at KCMU Co in the Biostats and Epidemiology program. And it's one of our Tanzanian track students or track trainees. So Baraka, pleasure to have you. Please guide us through your presentation.
Thank you, Prof. João, for the invitation. Good morning, everyone, and good evening, everyone. For those who are in Tanzania, good evening. So, as I was introduced by Professor João, I'm a PhD candidate under track D43 at the year 3 at KSMC University. Today, I'll be presenting one of my paper for a PhD, so that I'll just give a summary of what we found in the first paper. So allow me to share.
Are you allowed to share? All right, there you go.
Yes. Are you all able to see?
Yes, Baraka.
Okay, thank you. So today I'll just give a summary of one of my PhD paper, which look on the evaluation of the patient-specific functional scale in monitoring the pediatric injury patient at a zonal referral hospital in northern Tanzania, KSMC. This paper was published recently in BMJ, Pediatric Open. And if you look on the wall, we have some of the co-authors who made this work to be possible. So when you are going through the presentation, you are free to ask the question to any of the listed authors in this paper. You just get the answer on any concern on this paper. So I should acknowledge each and everyone for the contribution of this paper, who make this paper to be published in one of the nice journals. So today I'll take you through the definition of key terms, introduction, down to some of the selected references. So be aware on some of the abbreviation. PSFS, which stands for Patient-Specific Functional Scale. GOS-E, which is Glasgow Outcome Score Extended for Pediatrics, and also the MCID, which stands for Minimal Clinical Importance Difference. So I'll be using frequently this abbreviation, so be aware on that. So why did I focus on this? Traumatic injuries are the injury with sudden onset and severity level, which required the medical attention. So the type of the injury which were included or were analyzed in this study, or those injury which require the medical attention. Coming to the patient-specific functional scale, abbreviated by PSFS. This is a self-patient reported outcome, which measure how the individual identify important activities which that individual used to perform them before injury and face some challenges to perform the same activities after injury. In this case, we are assessing the PSFS from 0 to 10 scale, whereby the higher score indicates the better physical function. So the 10 score indicates the better physical function, where the lowest one indicate that there is a problem to a specific patient. So for this case, we have chosen 5 activities which children used to perform before the injury and face some problem after injury. So in this case, we select 5 activities, and these 5 activities were assessed into 3 time points. So at discharge, we assess the PSFS so that to see the score at the discharge. Then the same activities was assessed at 2 weeks post-hospital discharge to see if there is a significant change or recovery from the injury. Then again, it was followed again for 3 months to assess the score of patient-specific functional scale. And at this case, the same activities which were assessed at the discharge point are the same which was assessed at the 3 months follow-up. So when you talk about the PSFS, the patient-specific functional scale goes across with the rehabilitation management. So when you talk about rehabilitation, is a set of intervention which aim to optimize functioning and reducing disability levels to the individuals with health conditions such as injury and some other conditions. So the reason of this, we try to save the life, to improve the quality of life, and also to bring the independence to the individual after the injury. So rehabilitation is very important in hospital and also after hospital discharge. So why was I interested with the PSFS in pediatric injury patients? When you come to the statistics, trauma is among the leading cause of morbidity and mortality globally. So if you come to the injury, the 95% of pediatric injury-related deaths occur in low and middle-income countries are related to injury. So if you see 95% of the pediatric injury-related deaths occur in low and middle-income countries, including Tanzania. Approximately 800 children die every year as a result of an injury. So in Tanzania, where the study was conducted, pediatric injury accounted for nearly quarter of all injuries, including the adult injuries. So pediatric include quarter of all injuries. So approximately, despite this high number of the injuries, approximately 50% of patients in low and middle income countries who require rehabilitation service do not have access to this due to some resource limitation and some other constraints. So the patient-specific functional scale has proved to be widely used and effective assessment tool to evaluate the functional outcome across diverse patient groups, both in adult and in pediatrics. It has been validated and shown to be reliable and proven effective for musculoskeletal conditions. So it helps also to track progress over time to pediatric injury, enabling monitoring of recovery and timely adjustment to treatment plans. So the patient-specific functional scale has shown the personalized rehabilitation. So it helps to find a management toward the child-specific challenge or some other conditions. So despite all this advantage of the PSFS, as it shows, is a very easy tool to assess the functional change at time. Use in pediatric injury patients, especially in low resource setting, including Tanzania, remains underexplored. So this study will help to evaluate the PSFS at the pediatric injury patients so that we can come up with a tool to assess the functional change at a different time points. So what was the study objective was to evaluate the psychometric properties, including the validity and reliability of the patient-specific functional scale for monitoring pediatric injury patients at the zonal referral hospital in northern Tanzania. So the study area is KCMC, Kilimanjaro Christian Medical Center, which is located at Kilimanjaro, Moshi Urban. is a zonal referral hospital which receives approximately number of 1,400 in emergency medicine department. The study design was a cohort study design. The study population was pediatric patient presenting at the emergency medicine department with acute injuries. So the analysis include the pediatric injury patient from the year 2020 to 2024 June. So there are some of the patients who were excluded in this study or analysis due to some reason. One of the reasons of exclusion was those patients or those pediatric who injured older than 1 month, and also those pediatric injury patients who just came for a follow-up. So those type of patients were excluded from this study. So the aim of the measure or outcome of this study was checking on the mortality due to injury and the morbidities. As I said before, we had a follow-up interval of 3 time points at the discharge, 2 weeks post-hospital discharge, and then 3 months post-hospital discharge. So we had 2 comorbidity tools which were used to assess these outcomes. We had a PSFS and GOS-E for pediatrics. Coming to the analysis, as I said before, the psychometrics which was evaluated was reliability and validity. So coming to reliability, we did we assessed the internal consistency by using a Krobach alpha. So in some of the literature say that if you have the Krobach alpha of which is greater than or equal to 70%, it shows that the tools has good internal consistency. And also it ensures the coherence of PSFS item in measuring functional limitation. We did not end up checking the internal consistency. We also check the content validity so that we see if the tool can really evaluate the changes at a different period of time, looking on the flow effect and the ceiling effect. Also looking if there is a lack of flow or ceiling effect in which indicate the scale to detect variation in functional outcome. So looking on the construct validity, we try to correlate the tool PSFS and GOS. So looking on the correlation of PSFS and GOS, in this case, GOS was correlated with the PSFS because they have some similar way of assessing the functional change. Despite that, they go in a reverse way, whereby the highest GOS point indicate their poor recovery and the highest PSFS score indicate the good recovery. So if you look on this item, we classify the PSFS as a continuous variable, having the score of 0 to 10. The highest score means the good function, almost the normal functions. Coming to the GOS-E, we categorized it into 2 ways. Those with the good recovery and the poor recovery. The GOS had 8 points, so we counted 1 to 2 as a good recovery, 3 to 8 poor recovery. So this one was correlated due to some issues which are the same. Coming to construct validity, we also assess the direction and the strength of these 2 comorbidity tools. Also, we did not end there. We come checking on the responsiveness of the tools, whereby we evaluate the patient-specific functional scale ability to detect the clinically meaningful change over a period of time, from the discharge point to 3 months post-hospital discharge. Also, we check the coherence D, which is used to calculate the mean change in PSFS score divided by standard deviation at discharge, evaluating if there is real variation between time, and also looking on some errors in detecting the changes over time. So here are the summary of the findings from this study. As I said before, we had recruited the pediatric injury patient from 2020 to June 2024. A total number of 1,000 pediatric injury met the criteria of this study, whereby the median age was 7 years. Almost more than 50% of pediatric injury patients were male, and more than a quarter of the pediatric injury were due to road traffic injury. And almost 1% of the injured patients were referred to one of the rehabilitation units. And almost 7% of injured pediatric patients died. And in these cases, 27 or 42% of all deaths were due to burn injury. So you can see burn was leading on the deaths due to injury. Coming to the score, if you look on the score from the discharge to 3 months post-hospital discharge, we had a PSFS of 4.3 at the discharge, which improved to 9 at 3 months post-hospital discharge. Coming to the content validity, the flow effect was decreasing with time, while the ceiling effect was increasing in time. This shows that at the beginning, at the discharge, there were few patients who had improved, but if you come into the 3 months post-hospital discharge, there were a significant increase of the score. And if you look again on the mean difference between discharge point to 3 months post-hospital discharge, we had 4.8 mean difference of the changes of the PSFS score. Coming to looking on the content validity, on the correlation between the patient-specific functional scale and GOS-E for peds, we had the negative correlation of 74%, showing that these two functional scales, they are working reversely. So if you have the highest score for PSFS, it means that we had also the lowest score for GOS-E. As I said before, the highest score for patient-specific functional scale indicate a good recovery or a good function, while the highest score for the GOS-E peds indicate the poor recovery. So in the analysis, this shows that there is a negative correlation of these two tools, PSFS and GOS-E. So the PSFS demonstrated a good reliability because the Cronbach alpha for internal consistency was 90%. And if you look on the literature, they say that if you have a Cronbach alpha of 70% and above, it means the tool is reliable and good for assessing the functional change. We have a standard error measurement of 1, which is a good also. We have a Cohen D of 1.24, signifies a substantial difference in patient-specific functional scores. Also, we move and check on the MCID, looking on 2 distribution-based method. And we had a finding with the almost similar findings, whereby we have findings of 1.02 and 1.09 using a pooled standard deviation and standard error measurement. So they are almost having the same findings, showing that these tools has a good minimal clinical influence difference. Also, area under the curve was almost above 75%, which was 83%, which show that also there is a good or reliable of this patient-specific functional scale. So what to discuss? The patient-specific functional scale proved to be valid due to the internal consistency which shows, and also some other responsiveness and validity. Also, PSFS score showed significant improvement in functional status over a different period of time, and which was supported also with some other study which showed the excellent reliability, suggesting a high degree of internal consistency. Also, looking on the minimum clinical influence difference, which was 2.7, this was higher as compared to other study, which reported 1.2, and this may be influenced due to different population. The other study, which was for adult, reported 1.2 MCID. This difference can be influenced by the different population used. Also, the PSFS demonstrated strong accuracy with the area under the curve of more than 75%, which effectively distinguishing between patients with the significant function improvement. And there are several studies which supported this area under the curve. So, by conclusion, in summary, the PSFS is a reliable and valid tool to be used in this group because of the value of the Cronbach alpha for internal consistency, which was above 75%. Also, the area under the curve, which was above 75%. Looking on the responsiveness and other content validity, is sure to be reliable and valid. And it gives the strong psychometric property, as I said before, and also it captures the patient-specific concern. So this study had some of the strengths and also a limitation. One of the strengths of this study is most of the studies and the published study were conducted in adult population, and leaving aside this a vulnerable group, a pediatric injury patient. So this is a first study to be conducted focusing on pediatric injury patient in Tanzania. And also the study was able to capture a multiple assessment tracks functional change over a different period of time. There are some of the limitations. One of the limitations is the study was done in a single site study. Although KSMC, it received the diverse pediatric injury from a different part of the country. So it's a single site study, but the area captures pediatric injury from the different angle of Tanzania. Also, coming to the assessing the score, the patient-specific functional scale, for those young children below 5 years, we had a parental influence whereby the parents was playing a part to give a score to the child. So it can either overestimate the score or underestimate the score to these children. So thank you very much. I should acknowledge the funder of this PhD project, Trek D43, my supervisors, my mentors, KCRI and KSMC. And these are a few of the references used in this presentation. Thank you. Thank you so much.
Thank you, Baraka, for guiding us through